Okay, perfect. So thank you everyone for joining us for today's AME seminar. We have Philipp Seebock today, who's the head of the Medical Anomaly Detection Group at the Medical University of Vienna, and he'll be telling us about some of the projects that he works on over there. Thanks, Philipp. Take it away.
Yeah, thank you very much for the nice introduction. Happy to be here and give a talk. I try to prepare something that is interesting for you. And if anything is unclear, or if you're interested into something specific, feel free to interrupt me, ask questions in between. I'm totally fine with that. So we have an interactive session, so we can have an interactive session here. So the first thing I want to start with is actually this image. So as you can see, it's a calculator. It's a TI 83 Plus. It was actually released to the market about 30 years ago. But the question is why I'm showing this, and I'm showing this because I think there's a nice fun fact about it. It's basically that this calculator has 6 times more computing power than the computer that landed the Apollo 11 on the moon. So if you think about that, and given the fact that we have now all the computing power available, all these big models, all the data that we train the models with, we should probably also ask ourselves the questions: are we really maximizing the output of what we are doing here, right? So the computing capacity that we have available today is way more than that was available about 6 years ago for the computer, and they even managed to land the Apollo 11 on the moon. So from that perspective, I think we are currently on the threshold of a new way of thinking, of approaching things in medicine, and also a new way of how to apply technology in medicine. And I think it's super interesting, and I'm really curious about all these developments, and I'm happy to be part of this because we'll see a lot of really cool developments also in the next upcoming years. But before we'll talk about AI in medicine, I want to give you a short introduction about my academic journey, so you can better understand basically why I'm thinking the way I'm doing. So actually, I started here. It's the Technical University of Vienna. And it looks nice, and it's also a really nice city. So if you have the chance to visit Vienna, I highly encourage you to come. And if you come, just reach out to me, and I'm happy to also give you here a tour at the General Hospital or the Medical University. But in any case, right when you start your master's or your studies, it feels like, oh, well, you're now the one person who will change the world, right? But when you're visiting the first lecture, it feels a little bit more like you're a number. And that was at least my personal experience, and I know that many others share this experience as well. So actually, my take-home message for you is basically don't let it get you down. So keep your motivation and stay passionate, even though the system may not be optimized towards this goal. You can make a difference, right? So if you're curious about medical imaging and AI, keep this passion and continue your track. My personal fell in love moment with the things I'm doing right now was basically quite late in my master's. It was the lecture Medical Image Processing, where for the first time developed models to segment bones, basically in X-ray images. And so that was my moment where I really thought, okay, well, I want to go for this topic. This is the topic I want to work in. And yeah, so I hope that you had something similar yourself, maybe even earlier. So after I finished my master, I did my PhD here at the Medical University of Vienna in the General Hospital, and in my PhD, in a nutshell, I developed AI models for medical imaging. And my personal aha moment in my PhD was after 1.5 years, actually. I was given these type of images. So these are OCT images. So these are 3-dimensional images of the human retina. So these are really nice images because you can acquire them non-invasively in a few seconds. And it gives you high resolution in micrometer resolution image of the retina. But the task that was given to me was actually quite fuzzy, was discover something new and relevant in these images. And something that I did that seemed quite reasonable to me was I developed basically or tried out unsupervised feature learning methods. So I embedded patches with autoencoders. I mean, I did also other stuff, but basically that was what I'm doing at the first part of my PhD. And then I clustered these embeddings, and I realized these basically resembled all this healthy appearance. So this layered structure of the retina that you can see on the left side, which anatomically makes sense, but if you want to discover something new, it's not really useful. So I realized at some point that if you want to investigate something about diseases, about pathologies, about disease course, you first need to differentiate the normal appearance from the diseased appearance. So this is how I somehow ended up in the topic of anomaly detection. So I will come back to that at a later point of the presentation. After my PhD, I became the head of IT of the Vienna Reading Center. So basically, I was responsible for a team of about 10 people. So going from a developer to a project manager. I selected this slide because sometimes it feels a bit like you're just managing stuff and not developing anything. Which in the end, I would say was also the reason after 3 years that I decided to go back to research. And so I accepted a position as a postdoc PI now here at the CIR lab. So if you want to describe it from a localization perspective, I basically started here in the General Hospital as a master student, moved down from a PhD into this building on the right bottom, and then moved back to this building here when I became the head of IT, and then as a postdoc just moved a few doors because actually all the groups where I moved back and forth were from a location perspective quite close to each other. So one could also argue that I didn't came far, but that's up to you. Yeah, so one thing that I wanted to cover is how is personal life, right? So if you're doing research, you work hard, you have not so much time often or you have a lot of stuff you try to manage, and it's hard sometimes to do that. And at the end of my PhD, it felt a little bit like, being this creature here, coming out of a cave and discovering that there's something else beyond academia. So my message to you at this point is work hard, but always remember also to enjoy life. It will help you. And something that I also want to share with you is this image is because I'm a chairman of a soccer club since 14 years, and I'm also actively playing myself. And why am I sharing this to you is actually because I think there's a lot of parallels between playing football and doing research. And condensed down into one sentence, it's we're better in a team. So you can, of course, also do good research on your own, but you can do great research in a good team. So make sure that if you're doing research, pair up with other students, share your ideas with others, work in joint projects. That's at least in my experience, it's always an advantage to have someone or have others supporting you, and that you also can support, because you're always restricted by your own thoughts and by the way you're approaching stuff. And if you have others that that can help you with it and give you other perspectives on the things that you're also working on, that's super useful. And the last thing is mentors. So always make sure to have one or two mentors, not necessarily your PhD supervisor, or not restricted to your PhD supervisor. So that's always quite helpful to have people that support you. And in case Hrvoje, Bianca, and Georg are watching this by any chance in real life on YouTube, thank you, because these three persons were actually my mentors at one or other stages of my career. So it's really helpful to have them, these mentors. Are there any questions at this point? I mean, it's more on background and giving social advice, so to say, but okay, so if not, I will continue. So let's dive into it. So AI in medicine, of course, there is a lot of stuff out there, right? And there is a lot of approaches and cool developments going on. But I want to share my perspective how AI can help or can have a great impact in medicine. It's of course not the only one, but it's I think one perspective that gives you probably a different perspective and new insights. So all taken together, so what is precision medicine? What is biomarker discovery? So if you consider this point cloud and each point represents a patient, the first thing we want to do is, at least I would say, is early detection or detecting diseases or even detecting patients at risk for developing diseases. So to identify these patients in this cohort that may develop a disease or that are in an early stage of disease. So we need, of course, data to do that. And it's always important, I think, to remember that we cannot do anything with AI models without data. So that's also something that's probably not directly related to the research we're doing, but if you have the chance to influence how data is acquired, or if you see the opportunity to have influence on additional data that is acquired, or there may be a simple workflow change, the way the clinicians are working in clinical day practice and in everyday clinical practice. And if they are willing to do that, that's super useful. So I experienced that a simple change in workflow can result in much kind of a high impact in the quality of data. So just I just wanted to mention that as a side note. So beyond once we have identified those patients at risk or that already have developed the disease, the next step, from my perspective, is early identification of subgroups. So characterize those patients and identify those characteristics that are relevant for the disease, so the biomarkers. And then individual prediction is I think the next step, once you have identified basic characteristics of a patient, then to allow the optimal choice of therapy. So taken together, we have early diagnosis, identification of subgroups, and the prediction of treatment effects to choose the optimal therapy. So these are the three aspects where I think AI can really make an impact and difference. And once you have chosen, hopefully, the optimal therapy, but you never know, right? So there's always some uncertainty on that. So you also would like to track disease progression. And all that, all these applications are based on knowledge that we have about diseases. So based on biomarkers. So just to clarify that, so we are all on the same ground. So biomarker is basically a characteristic of a patient that is relevant for a certain disease, but this characteristic may not be relevant for different disease. So if you think about blood pressure, there's maybe a risk factor, so a biomarker for cardiac events, so cardiac infection, for example, but it may not be a risk factor for, I don't know, breaking your leg. If what researchers or basically what clinicians are doing with studies, they're trying to discover new biomarkers. They're trying to discover to increase the knowledge that we have about diseases. And I think we can have a great impact when we streamline this process of biomarker discovery. As I've mentioned already, I'm working with imaging data, and I think many of you do as well. So why is this so appealing? to work with imaging data, particularly with biomarker discovery. I think on one hand, it's non-invasive, at least most of the time. And on the other hand, it provides this sweet spot in the middle between detailed information about the patients and the number of patients that receive this examination. So it's detailed and provides big data, and both aspects are in the end needed for biomarker discovery. Okay, so now that you kind of better understand my perspective on how AI can, where I think AI can make a difference, let's have a look at what ways do we have to discover biomarkers in imaging data. So the first approach, I would say that these are kind of this is not a complete list, right? This is not a comprehensive list, but these are five ways that five general ways that we thought about how we can approach this problem or this concept of biomarker discovery with AI in medical imaging. So the first approach is traditional, I call it traditional supervised prediction. So basically you predefine or you handcraft features that you're interested into. So it's a hypothesis-driven approach. Then you basically put these features into a traditional random forest model, traditional machine learning model, and you evaluate the feature importance. So one example, for this biomarker discovery process that we did is basically prediction of treatment needs for patients with a particular retinal disease. So these patients we've called AMD, so age-related macular degeneration, they typically receive injections into the eye, and these injections are super expensive. So I do not know by heart what's the price today, but a few years ago it was about $2,000, depending on the company and the drug you chose. But so all of them have in common that you have this initialization phase where patients receive injections directly into the eye, so for 3 months. But after that, it's not clear. It's still also today not clear how many injections a particular patient will need. So basically, what doctors are doing is trial and error. This is of course not optimal because patients will get overtreated, so you will waste money, and on the other hand, you will probably also undertreat patients, so patients will lose vision, which is also not good. So doctors said that, well, there are two features we are interested into, which is basically volume of lesions. So particularly, it was two types of fluids they were interested into. And on the other hand, the thickness of the retina, because once they get seized, the retinal appearance or the retina starts to thicken. So we encoded that using segmentation models, basically, and then put it into a random forest model and looked at the feature importances. And what we saw is that for predicting these treatment needs, there were approximately 2 to 3 features really of importance, which was basically all located in the central area of the retina, which makes sense because there you have the sharpest vision in a nutshell. So it was basically fluid in the central region and thickness in the central region. One other way of discovering biomarkers is supervised deep learning, so basically training segmentation models. So first this is also hypothesis driven, so you define a particular structure of interest, you manually annotate cases, you train a supervised segmentation model, a UNet or whatever you want to use, and then you apply this model on a huge cohort, and you can analyze this huge cohort from a statistical perspective then afterwards. So this is quite obvious. Kind of the advantage here is quite obvious. If you would annotate all the images manually, basically, realistically, you would only be able to annotate a few cases. So just to give you a reference, annotating one 3D volume for one type of fluid took the ophthalmologist a full day, so really 8 hours. So And instead, if you have a proper segmentation model, you can basically analyze as many images as possible as you want, as long as they, of course, are properly segmented and are covered somehow by your training data set. So your model is generalizing good enough. So this is already work that is already quite old, so 7 years old, but I think it still shows quite nicely this approach. This is why I've chosen this one here, is that we developed a model for segmenting these types of fluid, so that we have also investigated before. So based on the previous work, we thought, okay, well, it's worth investigating these type of structures. So segmenting the retina as a whole, segmenting this so-called intraretinal fluid and so-called subretinal fluid, so different types of fluid in the retina once it gets diseased. And then we analyzed it on a large cohort, a large study cohort. And what we realized was basically that, or maybe start in a different way, doctors treated patients before that basically as long as they saw fluid. So, right, so I've shown you this treatment regimen before with this initialization phase and then try and error. And basically what they did was once they saw any type of fluid, they treated the patient. And what we discovered here was that this is not actually a good strategy, because one type of fluid, particularly this subretinal fluid, has a protective factor for vision. So doctors then, this is still discussion ongoing, but this really changed treatment strategy, at least for some of the doctors in the clinic. So a lot of doctors are not treating patients now with any type of fluid, but they're only treating patients as long as just the subretinal fluid is present. And if there's just the subretinal fluid present still, then they stop treating and they only start treating again once other type of fluids appear. So you see, in this way, you can really kind of investigate biomarkers and gain new knowledge about disease and disease pathogenesis. Another strategy is to use unsupervised or supervised deep learning, supervised deep learning, but instead of training a segmentation model, you can train a regression or a classification model in essence. So instead of defining a structure of interest, you can define a prediction or a target, an outcome of interest, and then let the model learn this relationship. So this could be a disease class or a function, in this case, a visual function, if you investigate the retina. So you need labeled data, of course, but not on a pixel level, but just on an image level. So you train a supervised classification model or regression model, and then you can use these interpretability techniques to investigate the relations that the model has learned. So basically, I guess most of you are aware of these techniques for interpretability, these CAM, GradCAM methods, integrated gradients, and so on, which basically highlight the important areas or the areas that were important for the prediction. And just in case you're using PyTorch, I usually use this Captum library. I think it's basically plug and play, so I can really recommend this one. How did we use this in our research? So we first developed a model to predict retinal sensitivity from OCT volumes. So basically what this means is we were going from a 3D OCT volume to a sensitivity map. So basically we predicted for each position in the retina how sensitive it is to light. So because this is a quite nice, has quite nice correspondence for visual function. I saw someone raise the hand. Is there a question? Okay, so maybe it was by accident. So yeah, just interrupt me. So feel free to interrupt me if you have a question. So basically we trained this model. So in the end, the model learned this learned to basically predict visual function from just imaging data, from structural information. And we used integrated gradients to generate these maps, these interpretability maps, and together with an ophthalmologist, we showed these maps to an ophthalmologist, and he derived three insights. So one was that, okay, areas of abnormal changes are important, which made sense because abnormal changes lead to a loss in visual function. Photoreceptors are important, which also makes sense because these photoreceptors are responsible for perceiving the light. But what was interesting is also that the area below the retina, so the choroid, was also highlighted. And that is something that we actually did not investigate before. So just keep this in mind because we will come back to that in 2 minutes. So for unsupervised feature learning is also a strategy to discover novel biomarkers. So basically, you do not need any labels. So you just train your model with an unsupervised method or self-supervised learning method, and then you evaluate the learned features in a clustered space, or you directly analyze the feature embeddings. There are multiple ways of doing that. We basically we did that for OCT images, and we used a simple denoising autoencoder to learn first local features. So we mapped each position of the retina, so this 1000-dimensional column basically you can consider in a 3D volume into a 20-dimensional representation, and that gave us basically a 20-dimensional feature representation at each position of the retina. And then in the second step, we also derived global features. But just for the sake of time, I want to focus now on the local features because I think it shows quite nicely how you can use these unsupervised embeddings for biomarker discovery. So here you can see in color always the activation of a certain feature. So orange is the fifth feature dimension, but the number in the end doesn't really matter. And below the feature activation, you have the central slice of the 3D volume of the corresponding OCT image. So you always on the left-hand side the highly activated feature example, on the right-hand side the low activation. So this one was also then analyzed by an ophthalmologist, and the first feature basically corresponded to a known feature, but it was not used before. It was basically the structure here. It's called hyperreflective. It's some hyperreflective material, some tissue, scar tissue in the retina. And we investigated that structure also in follow-up works, and it has some relevance also in disease progression. Then the second feature corresponded to a known feature, and it was used before. So basically, it was this intraretinal fluid I already mentioned before, and this is, I think, was a nice confirmation that what the model learned resembled also already common ground knowledge that we already had about the disease or about this patient group. And lastly, and this is now what I said, please keep in mind that the choroid is important. So this feature did not correspond to a known feature, but it seemed to encode some healthiness features, so to say. So you see in the left-hand side, highly activated feature. So seemed the patient had a quite nice visual acuity, so had a quite nice vision. And on the right-hand side, this feature is basically lost, and it's also correlated with a bad visual acuity. And yeah, this was basically referred to the vessel structure or the healthiness of the choroid. And this also makes sense because the choroid, the area below the retina, is basically also has some role in supporting the retina with nutrition and with oxygen and blood and all this stuff. So this was something that the doctors did not investigate before, but they're doing it now, basically. So that's, I think, really cool insight, derived from actually two different types of approaches. And the last thing, and it is of course the approach that I'm probably most excited about, is the anomaly detection approach, where the idea is that you only need a healthy data set or a normal data set, and you train your anomaly detection model on to learn the normal variability. So you only need normal training data. And then during inference, you detect the deviation from this normal variability, and these are basically your anomalies, or you can also consider them as marker candidates. So this allows you to focus your analysis then on these anomalies. So I've mentioned that before. So if you would, and I've shown that in the very at the aha moment slide and also in the slide before, that if you would analyze healthy cases in regions and diseased cases in regions, you can do that, but often in many cases there is a lot of healthy tissue that is basically hiding the diseased characteristics. So if you want to investigate them, it's somehow like searching for a needle in a haystack. So if you would, if you use anomaly detection to first separate these two regions, then you can identify also afterwards more nicely these categories of anomalies. So you can do clustering, you can do in-depth analysis of these anomalies. So one example for an anomaly detection technique is this one here, where we basically explored the uncertainty estimation, or we used the uncertainty estimation for anomaly detection. So it's based on this theory is based on these two papers here. So there are two types of uncertainty. So the first type is aleatoric uncertainty. So that's the uncertainty of the task or of the data itself. So you cannot change that. So in this example of street scene segmentation, if you look at the second column from the right, you see that there is a high aleatoric uncertainty in areas where you have low contrast, where you have low resolution. So basically that's something you cannot really change because it's inherent in the data in the task itself. But what is more interesting for anomaly detection is the epistemic uncertainty, is basically the uncertainty of the model. So what we saw, or basically it's also the definition of this uncertainty, is that the uncertainty is high in areas or in cases the model has not seen during training. So in this case, it seems like the sidewalk or this type of sidewalk was not apparent in the training data. So the model here, the segmentation model, shows high uncertainty for this type of sidewalk in this example here. So how can we use this to detect anomalies? So basically, it's motivated by two observations. So as I just said, the first one is that this uncertainty increases for data differing from training data. So if you think about it, if you have normal training data, then you would expect high uncertainty for out of distribution samples. And the other thing is the so-called organization or disorganization of retinal inner layers, the so-called drill. So in a healthy retina, you have this nicely organized layered structure of the retina. But in diseased cases, this structure gets lost. And we use basically these two properties, or we use these two properties to come up with an anomaly detection method or anomaly segmentation method. So in green here, we trained a layer segmentation model on only normal cases, and we did not use any manual annotations for that because there were already quite old traditional machine learning methods out there that we knew that work quite nicely for layer segmentation, but only in normal cases. But that's totally fine because our training data is basically only normal scans. And once we have trained our Bayesian unit on this layer segmentation task on only healthy data, we can then apply them, and this is the red part here, to detect anomalous areas in new scans. So you do not only get the layer segmentation for this new scan that basically also fails in these abnormal areas or these abnormal cases, but you can also derive a uncertainty map, and with some basically simple post-processing, you get quite nice and decent anomaly segmentation maps. So here you can see some qualitative results. So, and you can, I mean, it's quite clear that there's a nice overlap between the manual annotations and the anomaly segmentations. And I think this is really cool because this shows how you can kind of detect anomalies without any manual annotation involvement, actually. We also investigated multiple diseases. We did not have annotations for all of them, but what we saw from a qualitative perspective that the model generalized quite well to different types of diseases and different types of appearances. So as I mentioned before, once you have identified these anomalous regions, you can investigate them in more depth. And I would say in a proof of concept study, we clustered these regions. So basically, we took two patient groups, early stage and late stage AMD patients. We selected the number of clusters automatically. We then also looked at what type of clusters were learned. And what was really nice to see was that there were one-to-one correspondences basically between the early AMD and late AMD clusters, except one additional cluster for the late stage. And this more or less corresponded to fluid, which makes totally sense because this fluid is only apparent in the late stage of the disease. Of course, this did not provide novel insight at this point, but it, I think, shows quite nicely how you can investigate these anomalous areas. Beyond biomarker discovery, I think anomaly detection is quite interesting also for in screening cohorts. So we had this high-risk breast cancer cohort. So a screening cohort, so basically these patients that come regularly here at the clinic and they get an MRI scan of their breast. So what we thought we can, and most of the time they are healthy and nothing happens. So if you would like to train a detection algorithm, you would be, it's super hard. So we are also trying that, but it's super hard because you basically do not get enough training data to detect all these just small lesions and they're super heterogeneous and so on. So instead of just training a supervised model to do that, we trained an anomaly detection model to learn the normal variability of this healthy breast tissue or this healthy change over time. And then during inference, we detected deviation from normal. So because we had a lot of normal scans, this made a lot of sense. And just to give you an impression how you could use such a model in clinical practice. So in the first scenario, the patient is coming and over time, nothing is basically happening. So the model always says, well, this is all normal, so low risk for developing anything. So you do not have to do anything. But in the second scenario, in the first screening visit, the model will say, okay, well, there's no deviation from normal. But at the second visit, the model already detects some kind of deviation. So instead of waiting for a lesion to appear and segment it in a subsequent visit, you could do already an action at this earlier time point and shortening the screening interval, for example, or do some other action also depending on the actual performance probably of the model then in clinical practice, but also on preference of the patient and all this. And I think it's just a proof of concept study, but we achieved also an area under the curve of 0.8 in detecting future lesion emergence, which is, I think, quite cool. You can use also anomaly detection also to improve segmentation as such. So this is was a quite simple idea that we had. So instead of just training a segmentation model on the target of interest, you can train the segmentation model on the structure of interest plus the anomaly map that was generated by an anomaly detection model. So in the training process, there's basically not so much difference because you just have an additional class to train with. The only requirement is, of course, that you have an anomaly detection or an anomaly segmentation model that works quite robust for your data set. And here you can see some qualitative results, and what we think really helps the model or the segmentation model for detecting or for stabilizing the segmentation results is basically that you get somehow a context information, a semantic context information. So where are anomalies located? So the model has an easier task on focusing on the actual structure of interest. Just as a side note, we also played around with attention mechanisms, so taking the anomaly map and using it as directly as an attention map or attention mechanism in the network, so similar to the attention unit, for example, but that did not work out so well. Because I think the relation between the anomaly map and the structure of interest is not directly or is not bound towards kind of an attention, but it seems to have also some other relations that that are not kind of covered if you would just inject it as an attention map. Regarding biomarker discovery, we talked so far about static imaging data, but I think one interesting research line is to also learn patient trajectories and or to learn somehow the treatment effect over time or the disease course over time. And this is one example where we did this. So basically, we clustered the lung. This is lung imaging data. We clustered CT images of the lung, and then we at each position we looked at how does the cluster change over time. So, and then you can come up with this, I think, quite nice pathways of tissue change, we called it, because we knew kind of which patients were in an early stage and which patients were in a late stage. So we could really kind of draw this trajectory from more healthy clusters towards clusters that were more related to late stage disease. So this is not only interesting because it looks nice, but it's also nice because you could then infer, for example, if you have a certain type of cluster appearing in a patient, then this is a sign for, okay, this patient has a higher chance of progressing now to an advanced stage. And this is, we know that this is true because these treatment dynamics, we could use them to basically differentiate between patients that died earlier and survived longer. So, yeah. One other interesting research line, I think, is to also look at multimodal data. This is something that is, of course, investigated, but I think there is a lot of room for improvement and for development. So if you're into that, yes, go for it. There is a lot to do. But for one example, what we did is we linked histopathology data with MRI data. So we had MRI data of breast cancer patients. So it was a different cohort that I showed before. These were patients that needed surgery. But basically what we did is we trained a classification network. So based on the MRI data, we tried to classify cancer types that are usually graded only on histopathology images. And then based on this classification model, we clustered superpixels in the MRI, and we used so-called testing with concept activation vectors. So this is basically an interpretation method for models to link basically which clusters in the MRI are important for specific histopathology classes. And it's quite interesting because you can then visualize the clusters in the image. And what we saw is that some clusters or some histopathology types were basically correlated with the central appearance of the tumor, and others were more related with the border appearance of the tumor. And in clinical practice, this is interesting because usually it takes quite a lot of time to do this histopathology analysis. You need to also take a biopsy sample of the patient, which is also which is also a burden on the patient, of course, because it's actually a small surgery that you have to conduct. And if you can infer these histopathology types already from MRI imaging data, that would be quite cool because you can then act earlier and also would maybe in future be able to avoid this biopsy. So now we've talked about how we can use AI for biomarker discovery, but one thing that I also want to just shortly cover is basically future directions Or more provocative, so why haven't doctors been replaced by AI? Yeah, I think in general limitations or why isn't AI acting autonomously in all types of applications is that deep learning works well for narrow, well-defined tasks. When you have clear relationships, if you have big data sets, and if you have homogeneous data. And on the other hand, we know that in real-world medicine, this is not the case, right? So you have complex decisions, you have complex relationships, heterogeneous patient groups. You have often also rare diseases, or we have to struggle with data protection issues. So to put it into images, I think where deep learning really now works super nicely and basically things are solved maybe is these types of images. But in medicine, we often have to deal with these types of images, these other types. So I think one interesting line of research are foundation models. So that's something that I haven't covered in the talk before. But I think that current AI, to at least a certain extent, lacks so-called generalizable medical reasoning. And maybe foundation models are a way to close this gap. So right, instead of in traditional machine learning, you have one particular model for one particular task. You instead, in foundation models, you train your model with multi-model data. You train a very big model on a large data set, and then you either prompt the foundation model directly to do something for you, or you use it as an initialization for a smaller model that you can then fine-tune with less data. Right, so the intuition is that you have a joint learning and reasoning across tasks and modalities. And even though I think this is super interesting, I think one thing that is, I'm not sure if it's bothering me, but I think it's interesting that if we look at the sizes of these models, then I mean, we have an exponential growth basically. And if we look at the human brain, it would be located somewhere here. So basically, we have now already even bigger models than the human brain. And that somehow comes back to the questions we had, or the metaphor I had in the very beginning. Are we really doing the most out of the computational power and model size that we have? But yeah, I do not have an answer to this. I just think it's interesting that the models are already bigger than human brains. But what is interesting for us, I think, is that there are certain limitations, right? So we're not all Google, we're not Microsoft, who can just buy server farms for millions of or billions of dollars somewhere. So if you want to develop foundation models, you have infrastructure demands. So with ChatGPT-4, the estimated development cost, does anyone know this? I mean, nobody knows exactly, but the estimated costs, I tried to find it out, and to the best of my knowledge, it's $100 million. So if you would like to somehow resemble this for the medical domain, good luck. Usually, if you're lucky, you already have a research project that is funded with, I don't know, 1 million. Then you're already good. But yeah, on the other hand, I think the one limitation is, I think, still a certain lack of generalizability or bias. So I think that this generalizability or this problem that models are not really understanding the overall medical concept is still present. So we investigated this RedFound model, which was basically a foundation model for OCT images. And we found it worked good for DME cases, so one type of disease, but it did not work for AMD cases, or not so well. And we think it's basically related to the fact that this model was mainly trained with DME cases and not so much with AMD cases. And this is also actually my experience with other foundation models out there. So they are all only good if you use them somehow on very similar data they have been trained with, or on similar tasks they have been trained on. Yes, and then this is more a philosophical question probably, but I'm not sure if there may be still a lack of comprehension of this model. So there's this so-called Chinese room argument. I'm not sure if you have heard of this before, but basically this is stating that you have an actor in a closed room that receives Chinese symbols from the left, and then he has a book that basically tells him which other Chinese symbol to output. And even though to the outside world it looks like there is perfect Chinese communication, there is no understanding of the system. And this is something that maybe we can also discuss afterwards. But this is something that I think we just don't know. So is ChatGPT with billions of parameters just memorizing all the data in a certain way, or is it really understanding the outside world basically? And this brings me to somehow this is something that has been discussed at CVPR last year and I think also the year before, that there are two types of research that is happening nowadays at all the big tech conferences. So one is basically research engineering, and the other one is basic research. So on the one hand, you have the primary outcome products, and the other one is knowledge. So basically, you have the type of works that tackling fundamental problems, where the outcome is knowledge, and on the other hand, you kind of have this engineering where you scale data, you scale models, and the models just work better because they have been trained on bigger data set, and you just make them work from an engineering perspective. And I do not think that these are two separate research lines that are not interlinked with each other, but I think they can also very much profit. So I think we should probably we should not develop foundation models ourselves as smaller research institutions, but we should definitely make use of them and use them in a smart way. And that brings me basically to my last take-home message, so to say. So I think that we will perceive a shift of roles in medicine related with AI. So the first thing is this, what I mentioned, this AI towards autonomy in narrow fields and augmented for complex tasks. But I think what it burns down to in the end is that AI will not replace doctors, but doctors with AI will probably replace doctors without AI. I think this is something that actually, at least in our clinic, also doctors think it will be the case. And one other thing, and I mentioned in the very beginning, I think it would be cool if we would transition from reactive to preventive care. So instead of treating patients where already symptoms are present and diseases have manifested, it would be nice to derive models that can predict when a disease is going to happen. So in conclusion, I think we covered that AI can help to gain knowledge and can improve treatment in the end. But there are multiple challenges like data quality, data quantity, continuous change in medicine. That is something that I actually kicked out of the presentation, but I think this is also an interesting aspect, right? Because we have continuously changing devices, workflows are changing, new therapies are coming up. So if you have a model trained to predict the treatment outcome of two treatments that are available on the market, and then suddenly a third treatment is coming, what are you doing? And of course, multimodal data. So in case you're interested, there are more projects. So we're involved in, for example, this UCAIM project, which is basically an infrastructure project, where we're trying to build a platform to collect cancer imaging data across Europe. Then we are involved in AIPod, which is a project where we try to do this exact shift from reactive to preventive care, where we want to develop models that are able to predict cardiovascular risk, or how you can decrease your cardiovascular risk based on imaging data plus activity information collected by, for example, Fitbits or other fitness trackers. So yeah, but there are many more. So if you're interested, just check out our website. You can also ask me. So we are not the only group. So this is the last slide I have today for you. But there's like 15 labs all around. So if you're interested into what other people are doing here at Medical University, feel free to check out the CAIM Med Uni Wien website. Yeah, I hope you like the talk, and if you have any questions, I'm happy to discuss them.
Great. Let's give Philip a virtual round of applause for a very interesting and informative talk.